So in this case, we have a 68-year-old female, has a syncope episode, found to be pale, diaphoretic, only responding to verbals, so not doing so well. And that fact is further reemphasized by her blood pressure, which is 80 on palp. When we look at her ECG, I think it's pretty easy for you to get, or feel rather, kind of overwhelmed by just everything that's going on right here. And we're going to go through and break it down so that we can approach this and render this woman the appropriate treatment based off of what we're finding. So we're going to start first and foremost looking at this section of the rhythm strip. And as you'll notice, we've got these pretty large, broad complexes, and they're broad in the sense that the QRS is greater than 120 milliseconds. So this means we're dealing with some sort of wide complex rhythm. If you'll also look at the R waves and the relationship to one another, you may notice that it is a tachycardia because the rate exceeds 100 beats per minute. More specifically, it looks like these particular, or rather this whole section of this wide complex tachydysrhythmia is about, I want to say, 150 times a minute. When it comes to the intervals, we've got kind of a smorgasbord of intervals if we look at this entire strip, but for the purposes of just the first section, because again, we are in fact just breaking this down to make it easier for ourselves, we'll notice that the interval distance, at least as it pertains to the QRS, is going to be greater than 120 milliseconds. You may also appreciate that there do not appear to be any P waves preceding each QRS complex. And just to get into a little bit finer detail, we'll try to identify what is in fact a QRS complex and what is in fact a T wave, because I know that can be a little bit tricky. So remember that usually like the broader, deeper section of this whole mess of a strip. So this section right here is usually going to be your QRS complex. If we zoom into what is the T wave, you'll notice that there's a bit of a point right here where it kind of veers off to the right at a slight slope, and that's going to be your J point. And that's the section of the ECG where the QRS turns into the T wave. So for the purposes of this, our QRS is going to be down here, and our T wave is this section right here. But I digress. So what we have here is a section of ECG that is wide complex, regular, greater than 130 beats per minute, somewhere in the range of 150 beats per minute. And this is very kind of pathognomonic, these criteria of the wide, the regularity, and the rate is very specific for monomorphic VTach. And so we're going to throw that up on our differential. Let's do mono VTach or mono VT. Now, once we've got this little section kind of figured out, it's time to move on to all this stuff going right here. And so what we notice is that this is different from all this, and there's a reason for that. So this is actually a sinus fusion beat. And so sinus fusion beats are when the atria and the ventricles kind of link up in their electrical cycle and produce something that is actually closer to the normal intrinsic conduction pathways, and it kind of breaks this little episode of VTach. You may, however, notice that shortly after a couple of these fusion beats occur, that the rhythm kind of goes back into that wide complex monomorphic state, and we can assume, even though we can't see it, that it probably continues on that direction. So the purposes of this section here are really just to confuse your poor little brains at the moment, but it really is interesting because anytime you have this type of activity or fusion beat activity in the context of a wide complex tachydysrhythmia such as what we're seeing here, it actually really points to this being a monomorphic ventricular tachycardia. So that begs the question, what are we going to do when we're confronted with this? Well, just based off of how this rhythm is marching out, even though we did have a couple of sinus beats that are, in this case, fusion beats, it's fair to assume that she went back into the monomorphic tachydysrhythmia, so she's probably still in that 150s, probably still hypotensive, probably still not really well responsive. This means that we're going to be approaching this in the electrical arm of our treatment, and so we're going to start with the synchronized cardioversion. Beginning joule setting is going to be 100 joules, and then obviously we'll escalate if that is ineffective.